The premier event for infection prevention and control is coming to San Antonio this June. APIC's annual conference brings you the latest research, innovative products, and practical knowledge to help you prevent infection. From inspiring keynotes to thought-provoking panel discussions, APIC 24 curates an extraordinary platform for knowledge exchange. Meet IPs from around the world who face the same daily challenges as you. If you work in infection prevention and control, you don't want to miss this event. Learn more and register to join us, in person or virtually, at annual.apic.org.
You are listening to the 5-Second Rule podcast presented by APIC, the Association for Professionals in Infection Control and Epidemiology. This podcast is produced by the APIC Communications Committee and is intended to be a conversation between our hosts and professionals practicing in the infection prevention and control industry. You will learn and be entertained, but most of all, we hope you will be inspired by our community and the work of our peers. And now, on to the show.
Welcome to the 5-Second Rule podcast. We are your hosts. I am Kelly Holmes, and my preferred pronouns are she, her.
And I'm Lerenza Howard, and my preferred pronouns are she, her.
Hi, Lerenza. How are you today?
I am doing so well. How are you?
I'm good. Thank you. I'm excited to introduce our guest today, Rosie Bartel. So in recognition of Patient Safety Awareness Week in March, Rosie is joining us to tell us about her story. Rosie is a widow, mother, grandmother, and an educator. In August of 2009, she underwent a total right knee replacement that developed into a MRSA staph infection. As Rosie continues to battle this MRSA infection in her body, she's driven to share her story of survival. She believes in helping others with disabilities and other health concerns find their voices. She uses her story to co-design with medical professionals, researchers, and to advocate for patients and their caregivers. Welcome, Rosie.
Thank you for having me this morning, and I use the pronouns also of she and her.
Thank you, Rosie. It is such an honor to have you on the show today. It provides a different perspective as an infection preventionist to hear it from the patient lens about their experiences within healthcare facilities and how they're impacted by HAIs. And one thing that I would like to share from a personal encounter is that within my first year of being an IP, I actually had the amazing experience of watching a video regarding your story. And it left an indelible mark on me about my work as an infection preventionist and the impact that I have on my patients. For anyone that may not know your story, can you please share with us your lived experience that led you into the world and realm of patient advocacy?
Sure. So I had the knee replacement on August 17th of 2009, and I thought things were going well until about 10 days to 2 weeks later, I started developing some drainage or oozing around the staples. That eventually led me to having questions when I had the staples removed. Those questions were the doctor told me, once the staples are out, things will get better. Just give it some time. That was a Thursday night. By Monday morning, I was wrapping my leg in beach towels, and I knew I couldn't go back to work that morning, so I called the doctor and said, I think I have a problem. And he said, come in at 1 o'clock this afternoon. And once he looked at it, he said, I think I have a little window of time to change out the hardware and everything will be fine. And so tomorrow morning, be at the hospital at 5 o'clock. We'll change out the hardware at 7, and you'll be on your merry way to recovery. Now, this was my 6th joint replacement. I thought I knew everything about joint replacements, but I didn't know about MRSA and healthcare-acquired infections at that point. That joint replacement led to 58 surgeries, over 200 hospitalizations, more than 15 times in septic shock or sepsis and septic shock. I was not only taken by ambulance multiple times, but flighted several times to hospitals. I had 3 amputations and major skin removal. And I still have MRSA in my body, because one of the things that people don't understand about MRSA is once you have MRSA, you always have MRSA. And that MRSA stays with you. And so I have my pelvic bone is still infected with MRSA. The little bit of pelvic bone I have left, and it gets abscesses on it. And when those abscesses open is when I get an infection. And that's why I had the tissue removed around it, so that the infection doesn't always turn into sepsis and go into my bloodstream.
Wow, that is such an amazing story. And I'm so appreciative to have you here to share this with us, because it really sheds light on the level of quality of life that's impacted, that patients experience due to HAIs, and the importance of our work as infection preventionists in ensuring that bundle maintenance compliance is maintained and adherence to such infection control guidelines such as hand hygiene. So thank you for sharing that with us.
Yes, Rosie, thank you. Hearing you talk about 58 surgeries and 200 hospitalizations, like my stomach just drops. What a crazy roller coaster this life has been for you. So now you're in the hospital bed, you have this infection, you're septic, and you're on your 6th joint replacement. What's going through your mind, and how did you get into this patient advocacy role to tell your story?
It was the infectious disease doctor who invited me to the table. As I was dealing with him during the first year or 6 months to a year, he realized that I kept saying, we need to figure out why I got this infection and make sure nobody else gets it. And that was not an attitude that he was used to hearing. And so they realized they were having way too many MRSA staph infections from joint replacements. And so they were going to study it at the hospital. And he said, we've never invited a patient to the table. It's like airing your dirty laundry, he said. But he said, I think you need to be at the table. And I think that you will understand, that we're just trying to figure out why this is happening. And so it doesn't happen to anybody else. And so he invited me to the table. They were involved with IHI, Institute for Healthcare Improvement out of Boston, on a 5-year project called Project Joints. And during that project, they were in the 4th year, and they hadn't made any headways. And not only did they invite me to the table to help study why they were having so much MRSA, they also asked me to share my story at the end of that week with leadership. And leadership to me I guess I didn't understand leadership in hospitals at that point, but I thought leadership would be about 20 people around a table. It turned out to be a room full of 200 people. But because of my background in education, and I educated educators in the past, it didn't faze me, and I told my story. And at that point, we got everything we asked for. We went from 1 IP to 6 IPs. And that was a big investment for that healthcare system. And we created we saw lots of things that were happening in surgery and in hospital rooms and all over the place that we made changes. And we asked for changes, and they all happened. And because of that, lots of things changed in our world and in that hospital. And they went from 5% down to 3% within a couple months. And because of that, IHI said, what happened? And so then they told IHI about my story. And the story, the video that you saw, that 8-minute video that was made about 12 or 13 years ago, and is still used by a lot of hospitals today in orientation, and including the hospital where I had my initial surgery. They still use it. But that 8-minute video was done the day after when I came home from my first amputation. So I came home from my first amputation. The next day, IHI brought a camera crew and an interviewer to my home, and they created that 8-minute video.
Oh my gosh.
My
gosh.
The next time you watch that video, it's called One is Too Many. It's on YouTube. But the next time, when I watched that video, I'm like, oh my God, my counter was a mess. I hadn't been home in 2 weeks. My husband didn't keep my house the way I like keeping my house. Here's all this stuff on the counter. That's what I see when I watch that video.
Yeah, I only focused on your story. It was such a remarkable story. But your shared experience really highlights the necessity to have the patient at the table. And we discuss and talk about as healthcare organizations placing the patient at the forefront, but does that involve the patient at the seat, having a seat at the table and being a part of the conversation to implement measures to prevent HAIs? And what a remarkable feat to go from have the organization assist them with going from 1 IP to 6 IPs and really identifying that gap within the organization, but also commending the surgeon for the willingness to even invite the patient to have a seat at the table to really drill down on the areas where they need to improve.
I agree. It makes a connection, I think, in someone's heart and in their mind when you see the face of someone and hear the story of the patient experience. We can educate on those bundles and these elements, and we can do round after round and tell people this is what you should be doing. But I think it truly does help to hear that experience that you've had and to realize that every step that they take is so important in protecting our patients. So thank you for sharing that. And then I know that you do have a book, and it's called Rosie's Story, a story of faith, hope, and survival. So tell us a little bit about the book and where we can find it.
Okay, first of all, the book, it was not my dream, but it was my husband's dream, because every time I did the IHI video got me lots of presentations and lots of conferences. So I didn't need a book to get me inside a conference. I had the video that got me. People saw the video and they would call me and say, would you do this conference? Would you do that conference? But at the end of every conference, people would say, do you have a book? And I would say, no, I didn't. I'm a talker, I'm not a writer. Writing isn't my forte, talking is. But eventually I started putting down like little short chapters, experiences that I had and how I used that experience and why did I think that experience was important to be told to other people and especially to healthcare providers. And when COVID hit, I looked at my husband and I said, I think this might be the time that I should put all those little chapters I had written together and put them together and create the book. And so I did. I created the book between March and probably the end of April and put all those little chapters together. Several organizations and used it with quality improvement and in their settings. One professor at Harvard uses it as a textbook. And it's been used a lot of different places. It's not for sale on Amazon because I literally have signed every book. I put it.
Wow! That's
a
fantastic touch.
Yeah, and it's basically, if you want my book, if you put in my email, which is Bartel BARTEL 1949 @gmail.com. If you send me an email, I will send you the information of how you can get my book. And I do it, and I mail it anywhere in the world, and I have mailed it everywhere in the world, including Singapore, Africa, Brazil, all over the world, Australia.
That is such a remarkable effort that you've implemented to go above and beyond just you and your story, but to not only share your story, but to ensure that your work and your story is not replicated, to really partner with healthcare organizations and institutions to prevent HAIs in other patients, which is absolutely commendable. So I'm pretty sure, as you've noted, you learned about the field of infection prevention. I'm pretty sure prior to your experience with an SSI, you probably never heard of the field of infection prevention or infection preventionists. So with that, how do you feel about the work of IPs and their efforts in preventing HAIs based on all of the advocacy work that you've partaken in?
I have a lot of respect for IPs, and many times when they get pushed back, and I've been in meetings where I've heard them get pushed back, they'll say, you need to do this. And then they get pushback because people don't always think they need to do everything they should do. And yet when I share a story that will help them understand why what this IP is saying is so important, often they'll say, oh, I didn't understand that. Or I didn't realize, because my story and sharing parts of my story, not even the whole story, but even sometimes little snippets of, I was in the hospital and I got another kind of infection. I got C. diff, I got gram-negative, I got all kinds of healthcare-acquired infections, not just the MRSA on top of the MRSA. And because of that, and it was because of things that the IP often was talking about, but yet people weren't caring about. And even when, especially hand hygiene is one of those things where people don't always respect how important hand hygiene is, and they don't always do all the steps of when they deal with bodily fluids, and then why is it important to take off the gloves and still wash your hands? I think many times I've watched more than once somebody take off the gloves and then just walk out of the room, and I'm like, no, that's not what you do if you just change my bandages. That's, and it's not me. I always tell them, when I ask them to wash their hands, I always say, you can't give me any more MRSA than I already have, but you sure can take it to somebody else. Mm-hmm. And that's what I don't want to happen. And also, I said, you could take it home to your family. And so it's not just even me, but it might be the person that you're going to go home to tonight that you could take it home to. Do the right things, do the gowns, do the gloves, do the washing of hands with soap and water after you've dealt with bodily fluids. Do all those things because it's important.
Absolutely. And really drilling down, it really, just listening to you, it reinvigorates that notion of patient advocacy within my work as an IP. It's different to really provide education to stakeholders, to inform them about the policies and the protocols, but it's different having a Rosie Bartel story in your mind, understanding and knowing these patients that we're seeing walking our halls or going into their rooms to do audits, whatever it is your workflow requires, understanding the impact after they leave. We want to set a positive standard and to ensure that we are implementing protocols and procedures and following them to ensure patient safety at the basis of it all, and correlating the practice, such as people simplify hand hygiene, and as you've highlighted the importance of it, but we want to protect our patients, but we also want to protect ourselves and the community at large.
I agree. We do encourage patients to speak up because they're the ones in the bed watching the healthcare worker getting ready to take care of them or access their devices or change their wound dressing. And I think sometimes the patients feel like, oh, I shouldn't say anything. I shouldn't ask them to wash their hands. But I love the way that you framed it. And instead of it, do it for me, you want to keep me safe, just the way that you shifted that perspective to, I already have MRSA, but I don't want the person next door to get it either, to get it also. I think just the way you worded that, so powerful. I appreciate that. What tips do you have for everybody that's listening out there and they're like, how can I incorporate something like this at my hospital? What tips do you have for us?
I think that patient stories are so powerful, and when helping patients share their stories, and it's not just always with just the medical professionals, not just the nurses and the frontline workers and the doctors and the providers, but also people like environmental services, facilities, maintenance, construction, renovations groups. I present and have shared my story with hospitals that I've shared with every employee that works in one hospital. I'm going to go meet with them after this podcast today because they're opening a brand new ambulatory surgery site, and I'm going to be part of the dress rehearsal for having surgery in that ambulatory surgical site. And I'm going to have all the things that go wrong in surgery that could lead to an infection. And how do we deal with it? For me, I think the first of all, from this hospital that I'm working with and locally, I have never been a patient in that hospital, but they came looking for me after they heard me speak at the Institute for Healthcare Improvement, IHI forum one year. And when they came to ask me would I help them, I said, oh, definitely. And so I shared my story at first with leadership and then with perioperative groups and surgical groups. But eventually the head of facility came to talk to me, and he brought his whole team when he came to talk to me. And he said, my team needs to have a better understanding of infections and what their role is in it. And he and I met, and the first group I talked to was the maintenance group. And so it's 7 o'clock in the morning. Now, either the guys are ready to leave from their night shift or they're coming in for the day shift. But they're coming in an hour earlier than they would have to probably start work. And also, when I looked up, it was the first time I ever spoke to a whole room full of only men. And it was, oh my God, I'm the only woman in the room. I'm going to be telling them a story that they probably don't want to even hear right now about a patient and do they really want to know how their job could affect this? But I really framed it around the work that they do, and I empowered them to say something if you see something. I shared my story pretty much like I always do, but then I framed it about there are things that you might see that someone else may not see. Air exchange and why it's important that you change filters on a certain time scale. Or someone might put something in front of an air exchange. Or someone may not clean a bathroom the way that it needs to be. Or someone may put something where it shouldn't be. And even one of the things that one of the guys brought up even that day was that beds go into storage when they need a special kind of bed. And he said, and then we take it out of storage. And while it's in storage, who knows who sits on that bed or who is on that bed? He says, every time I take it out of storage and take it back to a room, I wonder, do they change the linens? But he said, I never felt like I could ask. And I said, first of all, you could ask. But I said, if I were you, I'd take those linens off while it's in storage. And then you have already solved the problem. And then they have to put on fresh linens and clean it. But the other story that was told to me later and by the facility director, he had a man that said less than 10 words a day. And they were having a problem in a surgical suite where the nurses and the doctors kept putting a table in front of the air exchange. And they would move the table, and then the table would be back the next day. And so this went on for about a week. And every time they moved the table, the next day the table would be in front of the air exchange. And finally, one of the guys said, I guess we're just fighting a losing battle. We're just going to have to leave it where they want it. And then this man who said less than 10 words a day said, and what would Rosie say about this? Mm. And immediately they said, Rosie'd say, if you don't get a response where you're trying to tell them why you're moving the table, then move up the ladder. So then they took it to their facility director, who then explained to him with the IP, he brought an IP with him to explain why this air exchange was so valuable.
Wow, Rosie. You know what? I shall deem you an honorary infection preventionist. Your inquisitive mind, your willingness to see even the smallest details, which is what we do as IPs. Stakeholders at times may think that whatever it is that we're pointing out is so small, but it's looking at the larger big impact and its impact on patients. But then just listening to you share your story, it also drives home the inquiry that we should have as healthcare professionals on, would we want our loved ones to seek care within our healthcare facilities? Would we want our children, significant others, whomever, best friends, to seek care at our healthcare facilities and really take that with you and go about your day as though you're caring for your loved ones? So thank you, Rosie.
I particularly like the story about the 10 words because then he probably had 4 words left for the whole day. That's very powerful that it stuck in his mind, and that's what he wanted to share, and that he did see it. So he said something
exactly
and elevated it to a point where things could get done. Because I do also see that at my hospitals as well. Maybe the OR staff, they see instruments not getting sprayed before they're going to sterile processing, or they see somebody come in maybe without washing their hands. And they feel like they can't say anything. And we're always like, put in an incident report. We need to have some kind of record of this so that we can, help. So I think hearing that is very powerful. And then reminding, every single person of that important pathway of, if you see something, say something.
Mm-hmm. And empowering them in the place. For me, it was like not only empowering them, but also making sure that everyone from the doctors down to the nurses to leadership realized that I was empowering them. I was not going to let them hang out there by themselves, but I told leadership, I'm empowering your staff, your environmental service staff, your maintenance, your construction people doing renovations. I'm empowering them. And I'm like, when they renovate a floor in this hospital, I'm on from working with the architects to make sure we put things in places where they might be better and collect less germs, through the whole construction. I now can read a blueprint, which I didn't read a blueprint before this started, mm-hmm. But I now read a blueprint and I look at all those things that when you lay in a hospital bed as often as I have, and you've been quarantined to a room as much as I have been, it makes you watch and see lots of things that many other people don't see. And for environmental service, many times when a patient is in quarantine, people bring in lots of things because they want to make sure they have everything they need when they come in to take care of you, and then they leave it because they have to leave it. And pretty soon your counter is just completely packed full of stuff that some frontline worker left. And I'm telling you, environmental services, because that's what I heard from environmental services, that many times they can't get to the counter. They can't clean the counters. They can't. And so I tell them, you can go to the desk and say, could someone come and help me clean up that counter so I can clean it the way I need to? And it's okay to do that. And one of the things I did at this hospital was last year on February 8th, I spent literally the full day from 6 to 6 at that hospital. And I did presentations for providers, for frontline workers, for environmental services, for maintenance, for construction, for everybody and anybody, and leadership, and everybody pretty much somewhere along the day came in to hear. But what was interesting is many of them came in to hear an area that they didn't work in. Like lots of frontline workers and nurses came in to hear what I was telling environmental services or what I was telling maintenance. And one of the things I did was I worked with the
CEUs
that they could get credit for it.
Oh yeah, so the continuing education. Yes.
The credits that they need, because this is a small hospital system, and they aren't able to send everybody off to conferences anymore. And so it's really important that we provide that kind of education on the floor when they need it. And this hospital now has gone into their 5th quarter without having any MRSA.
Wow.
And they've had 1 C. diff and 1 CLAMC.
Wow. That's amazing. And that drives home the fact that infection prevention is everybody's business. It's just not one department. It takes a multidisciplinary group in order to protect patients and visitors and staff. Of course, you have been working hard within the realm of patient advocacy, and I'm pretty sure you've seen plenty of things, both good and bad. Share with us some of the advancements that you've seen over the years and or the need for improvement as it relates to infection prevention control.
For me, I've seen, first of all, a lot of places where they've added infection preventionists and IPs. And I like that because I think it's important that we have enough people. Where I'm worried about is ambulatory services and ambulatory surgical centers, because at this point they're not required to have an IP on staff. And they share one, like one might come in once a week or something like that. But they're doing major surgeries there. They're doing hips and joints and all kinds of major surgeries that can lead to infections, and they're not being regulated the same way the hospital's being regulated. And so I figure sometimes you have to go in the back door in order to get people to put the money where they need to put it. And I started working with CMS about 4 or 5 years ago on measurements. And one of the things that we're really working hard is to get outpatient centers and ambulatory surgical centers to have to follow the same rules hospitals follow. Mm-hmm. In especially in those kind of areas like infection prevention and having an IP on staff and a lot of other patient safety issues. Right now, they're not required to report anything, but very soon, within the next couple of years, they will be required to report things. And that will make it become, I think, safer for patients. And it all comes down to patient safety and errors, and how do we make sure patient safety is taken care of, and how you're measured and how CMS looks at you and healthcare looks at you sometimes does help.
Mm-hmm. Oh, I totally agree with the focus on the ambulatory surgery centers. And they're doing high-level disinfection, they're doing sterilization. And in my personal life, when I have to have something done and I have a choice on, do you want to go to the hospital to schedule this, Kelly, or do you want the ambulatory surgery center? I always pick the hospital if that's the option, because I know that there's an IP roaming around at some level. And with the ambulatory surgery centers, I know that they do have people with expertise in that area. But I think that you're right. There needs to most likely be some regulations, some reporting requirements to keep it in line with just the standard of care that we would expect people to receive across the continuum. As far as incorporating this type of thing, we know that you're only one person, and I would love you to come to every single one of my hospitals and talk to them, but Absolutely. You're only one person. So it seems I can see maybe hospitals being a little scared or reluctant to reach out to a patient that has an infection or has had an infection from their hospital possibly, and ask them to tell their story and really have the hospital be vulnerable enough to be like, yes, we have a lot of room for improvement and here's where we're starting. So how would you recommend that hospitals who have not tried to include a patient advocate on their committees, how do they go about finding someone or incorporating this practice?
I think that you're absolutely right, Kelly, that there's a point when people are ready and not ready. And sometimes people go through all kinds of stages of grief. And when you get a healthcare acquired infection, you do go through grief. And I didn't go through the angry state. From day one, I wanted to fix this because I am a fixer. My life has been always trying to fix things. But my husband couldn't talk about it for several years before he was able to talk about it. I remember that they tried to ask him some questions the day they came to do the video at my house, and he just couldn't. He just broke down and was just sobbing because he just felt I had been let down, and our family had been let down. But yet I believe that there's a point when lots of patients and talk to your nurses may know, your infectious disease doctors might know, your wound care people might know. I was in wound care because I had VACs. I was in wound care every other day. They knew my attitude. They knew that I wanted to fix this, that I wanted to make a change. And an infectious disease physician knew. He saw me several times a week. He knew that I wanted to make a change. To the point where at one point, there was one wound care room that every time I would end up being taken care of in that wound care room, no matter who took care of me, I ended up with an infection, and I ended up within 4 to 5 days being septic and in the hospital with sepsis.
Oh, no.
And the first time it happened, I didn't think about it. The second time, I said something to the infectious disease doctor. The third time it happened, he said, Rosie, I think you're on to something here. I think we need to have this room literally taken apart and cleaned at every corner and find out why we're having this happen. Because I said to him, it's not the care I'm receiving. It's not. I've had different wound care nurses. You've been there. It's not the care I'm receiving in that room. There's something in that room that's causing me to get an infection. And then they started looking, and there were other people who were getting infections in there.
Oh, wow.
Who were having, problems with infections. Not to the serious level that I was, but then I was very close to. My infectious disease doctor told a cardiologist when I got AFib, don't worry about her AFib. She's going to die anyway.
Oh, my goodness.
And nobody ever told me I was going to die. And so I'm a survivor, and I just kept fighting to survive. But he told him, don't worry about not being able to give the drugs for and be able to treat the AFib because with blood thinners, because she's probably going to die anyway. And that was the take on it. But yet nobody ever said those words to me. So I was fighting to survive, and I was also sharing my story. And it's funny because during COVID, I shared my story on 6 of the 7 continents virtually. I do a lot of virtual presentations still, but I also now help train and work with patients to tell their story. How do you tell that 5-minute story? How do you tell that 6-minute story that's connected to what you're dealing with? Because it might be that they're dealing with not an infection, but something else that happened to them in the hospital from a healthcare standpoint. But yet infections are probably 3/4 of the reason readmissions of healthcare acquired things come through infections. And that's why it really, my old business card used to say on the back, and now I don't use a business card anymore, but it said on the back of it, my dream is a world without MRSA. Wow. And that is still my fight. And so when a hospital can say to me that they've gone 5 quarters without a MRSA staph infection, I feel that not only am I doing what I should do to help them, but they are also doing and hearing what I am saying. They are listening and they are working on it and they are taking it to the next level. And to me, it's not just me telling my story, but it's them taking it and using my information. Now, I always it's if you're going to present me a problem, I'm going to give you some solutions. And here's some of the ways that you might solve that problem without causing friction, because it's not, we're just working together to co-create a better healthcare experience for every patient. And that's my belief, that I want to work together with healthcare to create a better healthcare experience for every patient.
Thank you, Rosie. I know Kelly and I can sit here and talk to you for many hours more, but I want to thank you for your continued desire to fight and the work that you've done to prevent HAIs, not only to advocate for your personal health, but for the health of other patients and to see them thrive as well. And the latter part of what you noted is that you can share your story, but it's a matter of what the healthcare institutions will do with your story in order to prevent future infections. I just have a few takeaways from this episode, whereby it is absolutely integral that healthcare institutions not only empower healthcare workers to speak up, but also provide a voice and a platform for patients to share their experience, such that their lived experiences can continue to advance care and prevent infections. But then one of the things that really touched my heart in this episode is that Rosie noted that experiencing an HAI is like experiencing the stages of grief. And I would like for us as infection preventionists to really take that on with us as we continue the fight of preventing infections and promoting a safe atmosphere and environment for all individuals that come within our facilities. So, Rosie, thank you for your time and joining the show today.
Thank you for having me. I really enjoyed being with you today and hope that this is helpful to your organization and makes a difference this week during Patient Safety Week.
Rosie, you are a survivor. You have taken a very difficult journey and used it to make the world a better place. And I hope every time that you tell your story, you heal a little bit more. And thank you for sharing it with us. And good luck today at the Ambulatory Surgery Center. Go do your thing and make the world a better place.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5. where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.